Hello, 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 hello. We have started the stream. So, yes, let's start with gastrointestinal system. Okay, they have given embryology, anatomy, physiology, pathology, and pharmacology, the same as in endocrinology. Okay, a good set of bowels is worth more to man than any quantity of brains. Uh, Man should strive to have his intestine relax all the days of his life. Yes. All right, let's not panic. I'll make the money by selling one of my livers. I can get by with one. The truth does not change according to our ability to stomach it emotionally. Okay, when we are studying gastrointestinal system, be sure to understand normal embryology, anatomy, physiology, and how system affected by various pathologies. Study not only disease pathophysiology, but also the specific, but also its specific findings, so that you can differentiate between two similar diseases. For example, what specifically makes ulcerative colitis different from Crohn's disease. Also, be comfortable with basic interpretation of abdominal x-rays, CT scan, and endoscopic images. Gastrointestinal embryology, normal gastrointestinal embryology. Forget esophagus to duodenum. At level of pancreatic duct and common bile duct insertion, ampoule of water. Forget the esophagus. Forget esophagus to duodenum at level of pancreatic duct and common bile duct. Insertion, ampoule of water. 4th to 6th week of development. Stomach rotates 90-degree clockwise. Left vagus becomes anteriorly positioned and right vagus become posteriorly positioned. Midgut lower duodenum to proximal two-third of transverse colon. 6th week of development, physiologic herniation of midgut through umbilical ring. 10th week of development, returns to abdominal cavity rotating around superior mesenteric artery SMA 270-degree counterclockwise, 180 degree before 10th week, remaining 90 degrees in 10th week. Hindgut distal one-third of transverse colon to anal canal above the pectinate line. Okay. Pharyngeal origin is indicated in green, foregut in blue, midgut in yellow, and hindgut in orange. Cilia, trunk, aorta, superior mesenteric artery, inferior mesenteric artery. Okay, this is the foregut, this is the midgut, this is the hindgut. Ventral wall defect, developmental defects due to failure of rostral fold closure, that is sternal defect, ectopia cordis, lateral fold closure, omphalocele gastrocesis, or caudal fold closure, that is bladder dystrophy, bladder extrophy. Gastrocesis, omphalocele. Presentation, para-umbilical herniation of abdominal content through abdominal wall defect. Omphalocele, herniation of abdominal content through umbilicus. Coverage, not covered by peritoneum or amnion. That is A. Okay. The guts come out of gap cesium in the letter G. Associations not associated with chromosome abnormalities. Good prognosis. Coverage covered by peritoneum and amnion, is shown in the B. Light grey shiny sac. Abdominal content are sealed in letter O. Okay. Associated with congenital anomalies, that is trisomies 13 and 18. Beckwith-Wiedemann syndrome and other structural abnormalities, that is cardiac GU neural tube. Congenital umbilical hernia, failure of umbilical ring to close after physiologic herniation of midgut. Failure of umbilical ring. Congenital umbilical hernia, failure of umbilical ring to close after physiologic herniation of midgut, covered by skin. C. Protrude with increased intra-abdominal pressure, that is crying, may be associated with congenital disorders, that is Down syndrome, congenital hypopituitarism, not hypopituitarism, congenital hypothyroidism. Small defect usually close spontaneously. Okay. Failure of umbilical ring to close after physiologic herniation of midgut, covered by skin. C. Protrude with increased intra-abdominal pressure, that is crying, may be associated with congenital disorder, that is Down syndrome, congenital hypothyroidism. Small defect usually close spontaneously. Tracheoesophageal anomalies, esophageal atresia, EA. Trachea and esophagus. Esophageal atresia with distal tracheoesophageal fistula, TEF, is most common, 85%, and often presents as polyhydramnios in utero due to inability of fetus to swallow amniotic fluid. Neonate drool, choke and vomit with first feeding. TEF allow air to enter stomach, visible on chest X-ray. Cyanosis is secondary to laryngosperm. To avoid reflux related aspiration. Clinical test, failure to pass nasogastric tube into stomach. In H type, the fistula resembles the letter H. In pure EA, CXR shows gasless abdomen. Okay. This normal gastric bubble. In pure EA, esophageal atresia or stenosis, gasless stomach, pure distal esophageal fistula, distal tracheoesophageal fistula, H type, prominent gastric bubble, tracheoesophageal fistula, esophageal atresia. Esophageal atresia with distal tracheoesophageal fistula most common. So, that is the most common. Prominent gastric bubble. Intestinal atresia presents with bilious vomiting and abdominal distension within first 1 to 2 days of life. Duodenal atresia, failure to recanalize X-ray, shown in image A, shows double bubble, dilated stomach, proximal duodenum associated with Down syndrome. Jejunal and ileal atresias. Disruption of mesenteric vessels, that is superior mesenteric artery, ischemic necrosis of fetal intestine, segmental resorption, bowel becomes discontinuous. X-ray may show triple bubble, dilated stomach, duodenum, proximal jejunum, and gasless colon, associated with cystic fibrosis and gastrocytosis. May be caused by tobacco smoking or use of vasoconstrictive drugs, that is cocaine, during pregnancy. Intestinal atresia presents with bilious vomiting and abdominal distension within first 1 to 2 days of life. Duodenal atresia, failure to recanalize X-ray, double bubble, dilated stomach, proximal duodenum associated with Down syndrome. Jejunal and ileal atresia, disruption of mesenteric vessels, typically superior mesenteric artery, ischemic necrosis of fetal intestine, segmental resorption, bowel becomes discontinuous, X-ray may show triple bubble. Hypertrophic pyloric stenosis, narrow pyloric channel, thickened and lengthened pylorus. Most common cause of gastric outlet obstruction in infant, palpable olive-shaped mass due to hypertrophy and hyperplasia of pylorus sphincter muscle. In epigastric region, visible peristaltic waves and non-bilious projectile vomiting at 2 to 6 weeks old. More common in firstborn males associated with exposure to macrolates. Result in hypokalemic, hypochloremic metabolic alkalosis, secondary to vomiting of gastric acid and subsequent volume constriction. Ultrasound shows thickened and lengthened pylorus. Treatment: surgical incision of pylorus muscle, pyloromyotomy. Okay. Hypertrophic pyloric stenosis, most common cause of gastric outlet obstruction in infants, palpable olive-shaped mass due to hypertrophy and hyperplasia of pyloric sphincter muscle. In epigastric region, visible peristaltic waves, non-bilious projectile vomiting at 2 to 6 weeks old, most common in firstborn males associated with exposure to macrolates. Results in hypokalemic, hypochloremic metabolic alkalosis, secondary to vomiting, gastric acid, and subsequent volume constriction. Ultrasound shows thickened and lengthened pylorus. Treatment: surgical incision of pyloric muscle, pyromyotomy. Okay. Next, we are going to read pancreatic and spleen embryology. Pancreas derived from foregut. Ventral pancreatic bud contribute to uncinate process. Both ventral and dorsal buds contribute to pancreatic head and main pancreatic duct. Annular pancreas, abnormal rotation of ventral pancreatic bud forms a ring of pancreatic tissue. Encircles second part of duodenum may cause duodenal narrowing, arrows in A, and vomiting associated with Down syndrome. Pancreas and spleen embryology. Stomach. Pancreas derived from foregut. Ventral pancreatic bud contributes to uncinate process. Both ventral and dorsal buds contribute to pancreatic head and main pancreatic duct. Annular pancreas, abnormal rotation of ventral pancreatic bud forms a ring of pancreatic tissue. Encircles second part of duodenum may cause duodenal narrowing, arrows in A, and vomiting associated with Down syndrome. Pancreas divisum. Ventral and dorsal parts fails to fuse at 7 weeks of development. Common anomaly, mostly asymptomatic, but may cause chronic abdominal pain and or pancreatitis. Spleen arises in mesentery of stomach, dorsal mesogastrium, hence mesodermal, but has foregut supply. Celiac trunk, splenic artery. That is annular pancreas and pancreas divisum. Okay. At this point, I'm just reading all of the content, but I'm sleepy. But we have a discipline and we're going to read it, understand, correlate all the points to build a conceptual understanding. And that conceptual understanding we are going to test to build clinical reasoning by solving MCQs to treat real world patients. Retroperitoneal structures. Retroperitoneal structures. Image A are posterior and outside of peritoneal cavity. Injuries to retroperitoneal structures can cause blood or gas accumulation in retroperitoneal space. Okay. Sad occur. Suprarenal adrenal glands not shown. Aorta and IVC duodenum second part. Second through 4 parts. Pancreas except tail. Ureters not shown. Colon descending and ascending. Kidneys, esophagus, thoracic portion not shown. Rectum partially not shown. Okay. Ascending colon, descending colon, IVC, and aorta, right kidney, left kidney. These are all retroperitoneal organ, posterior and outside of peritoneal cavity. Injuries to retroperitoneal structure can cause blood or gas accumulation in retroperitoneal space. Ascending and descending colon, IVC, AO, right kidney, left kidney. Okay, got it. Important gastrointestinal ligaments. Okay, let's see these ligaments. Liver, stomach, portal triad, spleen, kidney, splenorenal ligament, hepatoduodenal ligament, hepatogastric ligament, falciform ligament, gastrocolic ligament, transverse colon, spleen, stomach, liver, diaphragm. Ligament connects structures, content, and nodes. Falciform ligament, liver to anterior abdominal wall. Structure, content, liver to anterior abdominal wall. Ligamentum teres hepatis, derivative of fetal umbilical vein, patent para-umbilical vein. Notes, derivative of ventral mesentery, hepatoduodenal ligament, liver to duodenum, portal triad, proper hepatic artery, portal vein, common bile duct. Derivative of ventral mesentery, Pringle manure. Ligament is compressed manually or with a vascular clamp in omental foramen to control bleeding from hepatic inflow source. Portal vein, hepatic artery, versus outflow, hepatic vein and IVC. Borders the omental foramen, which connects the greater and lesser sac, parts of lesser omentum. Hepatoduodenal ligament, liver to duodenum, portal triad, proper hepatic artery, portal vein, common bile duct. Derivative of ventral mesentery, Pringle's manure. Ligament is compressed manually or with a vascular clamp in omental foramen to control bleeding from hepatic inflow source. Portal vein, hepatic artery versus outflow, hepatic veins, IVC. Hepatogastric ligament, liver to lesser curvature of stomach. Gastric vessels, derivative of ventral mesentery, separates greater and lesser sacs on right side. May be cut during surgery to access lesser sac, parts of lesser omentum. Gastrocolic ligament, greater curvature and transverse colon. Gastroepiploic arteries, derivative of dorsal mesentery, parts of greater omentum. Gastrosplenic ligament, greater curvature and spleen. Short gastric left gastroepiploic vessels, derivative of dorsal mesentery, separates greater and lesser sacs on the left, part of greater omentum. Splenorenal ligament, spleen to left pararenal space, splenic artery and vein, tail of pancreas. Derivative of dorsal mesentery. Okay. Let's read digestive tract anatomy. Layers of gut. This is going to be our last topic for today. Layers, digestive tract anatomy. Layers of gut wall. A inside to outside. MS. Mucosa. Epithelium lamina propria muscularis mucosa. Submucosa include submucosal nerve plexus, Meissner secrete fluid. Muscularis externa include mesenteric nerve plexus, Auerbach motility. Serosa and intraperitoneal adventitia. When retroperitoneal. Ulcers can extend into submucosa, inner or outer muscular layer. Erosions are in mucosa only. Frequency of basal electrical rhythm show slow wave which originate in interstitial cells of Cajal. Duodenum, ileum, stomach. Mucosa, epithelium lamina propria muscularis mucosa. And submucosa, and then submucosal nerve plexus, Meissner, and muscularis, inner circular layer, mesenteric nerve plexus, Auerbach, outer longitudinal layer, and then serosa, mesentery, vein, artery, lymph vessel, and lumen. Digestive tract histology. Esophagus, stomach, duodenum, jejunum, ileum, and colon. But okay, we'll read this one also. We still have 3 minutes of time left. Digestive tract histology. Esophagus, non-keratinized stratified squamous epithelium, upper 1/3 striated muscle, middle and lower 2/3 smooth muscle with some overlap at transition. Stomach, gastric glands, a parietal cells of eosinophilic pink. Cheap cells are basophilic. Duodenum, villi B and microvilli increase absorptive surface. Brunel's gland, bicarbonate secreting cells of submucosa. Crypts of Lieberkühn contain stem cells that replace enterocytes / goblet cells and Paneth cells that secrete defensins, lysozyme and TNF, and plica circularis, distal duodenum. Jejunum, villi, crypts of Lieberkühn and plica circulare, taller and more prominent, numerous osseous ileum, leads to feathered appearance with oral contrast and increased surface area. Ileum, villi, pair patches, arrow in C. Lymphoid aggregates in lamina propria, submucosa. Plica circularis, proximal ileum. Crypts of Lieberkühn, largest number of goblet cells in small intestine. Colon, groups of Lieberkühn with abundant goblet cells but no villi. D. Okay, so last minute we'll check whatever we read in this session. We started gastrointestinal system. We started from embryology, normal gastrointestinal embryology we read. Then ventral wall defects, gastrosis and omphalocele. We have seen congenital umbilical hernia, tracheoesophageal anomalies, intestinal atresia, hypertrophic pyloric stenosis, pancreas and spleen embryology, and gastrointestinal anatomy we started, retroperitoneal structures, important gastrointestinal ligament we have seen, digestive tract anatomy we have seen, digestive tract histology we are looking at now, and we have looked it. So from tomorrow in next session we will start from abdominal aorta and branches. So that was our session for today. See you all in the next